Joanne. I promise I won't live up to that wonderful introduction. And the question came up about what is music yesterday, and you addressed that in your talk. And the Wild Music exhibit, I think, pushes the boundary on that. And I can tell you that when the National Musical Arts Board got together to try and answer that question, we came up with really no answer other than that quip when the question was put up to the Supreme Court about what is pornography. You know it when you see it. Well, you know it when you hear it. And also that we all use sound, and really it's a form of the art of sound, and not to withhold crossing the boundary between what we might consider to be music as opposed to sound when we're in the throes of wanting to make somebody feel better. And in the context of this conference, of course, when it comes to dealing with pain, the worst of all types of human suffering, I think, since it involves both the psychological and the physical. Is there a laser pointer up here by any chance? Do we have a laser pointer? I usually bring one, but I'm sorry to say that I was remiss. Okay. One point that I do want to emphasize for all of us as clinicians who work with patients. We don't work with clinicians, we don't work with healthy college students on experimental psych or brain imaging tasks, because we work with a very diverse population of people of all age groups, from all ethnicities. Of course, one of the beauties of working in New York City or Los Angeles is we're truly a melting pot of people from diverse backgrounds, and we have to remember that music is universal. Everything that Noam Chomsky said about universal grammar in language applies to music. It's acquired. You think of universal grammar as the child's toolkit coming into the world at birth, and that it's acquired without conscious effort, and it's acquired by everyone. It's not taught, it's learned passively, and that everyone has it. All cultures have it in a wide variety. And I put this slide up to remind us this is actually a Time Life photograph of the year from December 2001. I wouldn't think we would still be in Afghanistan at this time, way back then. But this is a woman soon after the U.S. Army went in and freed the Afghans from the oppression of the Taliban. And for the first time, women and the Afghans were able to dance and enjoy music. And this is a woman at her wedding without having to wear any head garb, playing a tambourine, singing and dancing. You could see John Montanaro in the background there. He's married already, so we can't invoke John there really as the husband, although one might wonder what he was doing there. Of course, you know, maybe that religion, I don't want, John's an Italian Catholic, or I'm an ex-Catholic, and I don't want to really talk about that now, but, and I wanted to show Joanne here, who has just an incredible experience with neonates and premature infants. I've just barely touched upon that field, and she was generous enough to publish a paper that I wrote with what little work I've done there, but Joanne has devoted her life to this. And when we talk about whatever it is in neurobiology and psychology, but when we talk about universality and innateness, we're talking about biology. And we have to remember, therefore, that the universality and innateness of music speaks to its biology among humans. And the work that you're doing in medicine and medical therapy, however it might be viewed, is addressing the fact that it is a fundamental part of the biology of humankind. And I think as part of the keynote, I do want to acknowledge Joanne and John, not so tongue-in-cheek here, but really I think acknowledge them and thank them here for putting together this conference with all of us, and they deserve a round of applause. Now, how many of you were at the New York Academy of Sciences lectures about a year ago that Dory Berger and colleagues put together? One point of this lecture and the lecture that I gave there is to provide a conceptual framework for understanding how the brain works in general, and then try to map out onto that how the brain works in relation to music. And anyone who's gone to medical school or graduate school in the neurosciences has to be sensitive to the bewildering number of terms that get thrown at you. The number of anatomical terms that one hears that are oftentimes go unexplained. David Hubel, a Nobel laureate who I was lucky enough to have as my thesis advisor in neurobiology, quipped one day to me, anatomists would rather use each other's toothbrushes than use each other's terms. And to some extent this is true. So you'll have different speakers come in using different terms for different areas, and there are so many different areas, it's very easy to get lost. And any of you who've studied philosophy or interested in philosophy or have come across Wittgenstein and his ilk may know this, the other quip that language is a game. We just give terms to things, but they don't really capture conceptually what those things out there in the world mean, what those concepts are. So I do want to take some time to flesh out those concepts a little bit and spell out some terms and try to simplify what all of us in the neurosciences who talk about anatomy and who talk about function, what it is that we're talking about. And talk a little bit about what these techniques are and what their shortcomings are, because when the press gets hold of it, it makes it sound like, there's no controversies, like this is the answer, this experiment actually means something, when each experiment in and of itself means relatively little, okay? So first of all, in the upper left here is Franz Gall. And Gall has gotten a bad name because if you just take a little moment, can you feel around your skull, okay? So if you look around, look at your neighbor for a moment. Just like stare at your neighbor. I know this is almost like a Catholic Church thing, and shake their hand and say, God be with you. No, stare. Next time you're in church, when you say, peace be with you, don't do that. Stare at their skull. And when you feel your skull, so, do they have the same shaped skull that you do? And then feel around your skull and see if you could find any bumps or protuberances that you think really make your skull kind of stand out in one place, okay? And what you're doing in there is engaging in the study of the skull, or phrenology. Now, people, including me, I make fun of Gall a lot, but actually he was a neurosurgeon who worked in prisons and asylums. And he studied the brain, but he tried to relate the shape of the brain to the shape of the skull. And he was an obsessive compulsive neurosurgeon. And he made endocasts of skulls. But he did an important thing, is he moved the focus of the brain from the ventricles, which are really just sewers in a sense, to the rind, as the Germans called it, or in Greek, the cortex of the brain. And although he didn't take the next step in the science, he became sort of a pop star in Europe. And he went around Europe in tours and lots of different things. And he ended up, as many pop stars in Europe would happen to them, he got condemned by Franz II, and he got in a lot of trouble and eventually ended up in places like England that liked the idea that there were people down here and people up there, and that you could tell the difference by looking at their skulls, okay? So as bad as that science or pseudoscience turned out to be, it represented a shift in thinking about what was important, what part of the brain might be important to look at. What we can see in scans, the only thing we can see in scans, and if you look at these fMRI images, they're always superimposed on an MRI. You don't actually see, and they're all averaged. They're not single-person scans. There's some abstract representation of an averaged brain from multiple people's scans in almost all of the cases you look for. It's true of all of the PET scans you look at. They're pretty because they're in color, okay, but they're averaged. They're not one person's picture. What we can do, and of course what we always do for individual patients, is get MRI scans. And with MRI scans, what you see are, how many of you have ever had, I don't have you say it in Greek, and on part Greek it's a little embarrassing, a gyro, a hero, a gyro? Okay, well the gyrus of the brain, when you hear the superior temporal gyrus, the frontal gyrus, it's like a rolled up part of the cortex. It's the same root of the word as that sandwich, right? So you have, like 20 odd sandwiches, and they each have a name. So I don't know, maybe you'll never order another one. Right? I'm sorry, I know I'm going away from the mic. I'll try to speak up. So notice there's a little bit of an eye of the beholder problem, which everyone has. But you see, this is one sandwich. There's another one. There's another one. Right? So that's the temporal lobe. So that's superior, middle, inferior. And on an MRI, those you can actually name. So that's really the only thing that we can name with the naked eye. That's gross anatomy, because you can see it with the naked eye. And that's what we use. Everything else relates to some of these other terms that you see. Like anytime you see numbers, that's microscopic anatomy. And that is even more of an eye of the beholder phenomenon, because this great German anatomist who had to have OCD would cut the brain into tiny little spaces and number them based on how the cells looked, their shape, how many there were across 3 millimeters thickness, and change the number based on how they looked under a microscope according to their size, the density of the different cells across those 3 millimeters, and so forth. And that seems like really hardcore science, right? Except another great from Hungary, instead of having 40-odd areas, he had 107. So who was right? Right? Economo, he's great. Brodmann, he's great. Who's better? There was no Super Bowl in those days for anatomists, so they didn't have any way of deciding. And the only way to do that, so when someone on an fMRI scan, no less an MRI scan, puts a Brodmann's number, right, they should be beheaded. The only way to do it, everybody's a little different anyway, so the idea of an average brain requires warping. So all these fMRIs you see are warped to a dead French woman's brain from 70 years ago. Never mind the warping, you have to kill them and look at it under a microscope. There are reasonable approximations. I'm kind of exaggerating as a way of reacting to the fact that you're being sold in the press, if not by neuroscientists, these facts without everyone going through for you the fact that there's warping and people are estimating microscopic anatomy through the gross anatomy that we can see. But be that as it may, what we can name on each and every patient are those gyri. Pretty well. There are boundary issues, but we can do that pretty well. Now, the idea that Gall was trying to push, and which soon thereafter became highly popularized by Broca and Wernicke, and the 19th century Germans were great at this, and we've added to that literature, but the foundations of it can be found in the European literature of the late 19th century, is this idea of localization of function, that in a particular area of the brain, we can localize a particular function like language, music, memory, and so forth. And I've circled here the apocryphal map of the phrenologists. This is the extreme idealistic and now we consider absurd construct. And you can see where they put tune. It's actually not too far off. But actually, as we'll see, music is widely distributed. The way we think of it now is that each function is a widely distributed system with multiple nodes. It's almost like if you think of a cellular network with multiple nodes, each of which has different functions. It's not that it's the whole brain per se, the way that Lashley thought of the brain as not being really locally differentiated, but if you think of it as a network where there are nodes that are connected to each other, that's more how we think about it, and each of those nodes has a different function. So this is considered apocryphal. If you look, this is again a little bit, I don't know if this is a coincidence. I had to blow this up. There's things like up here, benevolence, comparativeness, human nature. And I found this photo of Gall. I mean, that's like the biggest skull I've ever seen. I mean, is it any surprise that he got interested in the skull? And that he put comparativeness and benevolence and so forth over there? I mean, wow. Gee. Okay. If it's impossible to remember all of these things. I mean, it's just ridiculous, right? So let's try to keep it at Miller's magic number 7 plus or minus 2. George Miller's famous limits on human information processing capacity. There are 4 lobes, and they're numbered here. The frontal lobe, the temporal lobe, the parietal lobe, and the occipital lobe. The way to find them actually is not necessarily to look for the lobe, but to look for the fissures. So this is called the lateral fissure, because it's on the side, laterally, named after Sylvian fissure, and that separates the frontal from the temporal lobe. And then a little harder to find is this central fissure. So probably the precentral and the central fissures can be difficult to tell apart. So it's probably this one here, because there's a post-central gyrus and a precentral gyrus. Okay? So that's the central fissure. And that separates the frontal lobe from the parietal lobe. And then the occipital lobe, you know, is going to be the one in the back. And where to separate the occipital from the parietal and temporal, again, it's a little bit of an eye of the beholder, but I think you can see there's kind of a vertical line here. It can be a tough call. So these are kind of horizontal, but then there's a vertical line. So that's the occipital lobe. And if you can remember the 4 lobes, then you can start to chunk and try to remember the gyri within them. For the auditory cortex, almost all of the auditory cortex, so superior means the top, so the gyrus on top is the superior temporal gyrus. So almost all of the auditory cortex is here. Okay? Now, a footnote is, I don't know why in neuroanatomy people talk about the prefrontal cortex. That would be over here. It's a term that, because there's a motor cortex, right? And then somebody decided to say premotor, but it really should be motor association. So somebody didn't want to say premotor. So they said prefrontal, but really technically, according to the Greek, that would be over here. But you're going to hear that term. It's hard to get rid of terms. Then here, so this is the cerebellum. There are actually more cells in the cerebellum than there are in the cerebral cortex. It's very much involved with motor coordination, sensory motor integration for all modalities. And the brainstem is here. Now, we've done some work with MRI where if you took, actually this was done before MRI, where a German scientist took some gold foil and he put it around all of the cortex, which again, it's like an orange peel. If you know when you peel an orange, so imagine you peel the orange, right? So it's the rind or peel, that's cortex in Greek. So ours is 2 to 3 millimeters thick, and it's about the size of a small Domino's pizza. Okay, if you flattened it out. And in that little thin crust, there are 20 billion neurons. But now those are the information processing units. But each of those neurons makes 1,000 connections. So there are 20 trillion connections. And that, the cortex, is where almost all, I can't say all, but all of intellectual life and much of aesthetic life, at least as a lot of intellectuals think of it, happens. And if you don't have a cortex in the clinical world, no cortex, and you survive, that's the persistent vegetative state. So how does anatomy relate to behavior? Which is when we see patients, they're behaving. We're not directly looking at their brains. All right, now this is a complicated slide, but I want to simplify it by saying, instead of talking about 20 plus gyri and 40 plus Brodmann's areas, we're only going to talk about 3 broad functional subdivisions of the cerebral cortex. Okay? I'm actually going to start by just making a very simple statement about the left and the right hemispheres before we get to each hemisphere. All right. How many of you are left-handed? Okay, and of you, how many do just about everything left-handed? Yeah, so it's very rare. And how many of you do just about everything right-handed? Yeah, so it's very rare to be very strongly left-handed. Most lefties are mixed-handed. Like, I'm mixed-handed. Actually, the way the motor cortex is organized is by joint. So those of you who are left-handed, and I'm right-shouldered, but I'm left-fingered. And the way that the motor cortex is organized is very much on the control of muscles around the joints. And no one really knows why there should be that bias in laterality. Animals, by the way, do have laterality. It's not perfectly, each of them are more handed. If I spent a lot of time with rhesus monkeys, they consistently will take more often with the peanuts and so forth with one hand than the other. I don't know what the distribution is in terms of left and right, but they have handedness too. Now, language is a lot of different subfunctions, right? There's the comprehension of speech, there's groaning and moaning, there's saying single words, there's giving a talk. Actually, what Hewlings-Jackson called propositional speech, articulating an idea, that's a left hemisphere function. Actually coming up with a truth proposition, what Bertrand Russell or Wittgenstein would talk about in terms of language logic, saying something that you could test as being true or false. That's, even for lefties, 2/3 of lefties, so let's say if you write with your left hand, even 2/3 of lefties are going to have left hemisphere lateralization for propositional speech. Now, how many of you drive a car? Okay. Navigation is very much a right hemisphere function. But you don't really, or hopefully, especially in New York, where your reaction time has to be short, you're not actually thinking to yourself, okay, I'm going to turn on my signals and change into the right lane as this cab is coming from behind me towards my blind spot. That doesn't work. And you know often by sometimes giving directions doesn't quite do it. Right. So generally speaking, the strongest lateralized functions have to do with grammatically and semantically complex speech and spatial cognition. Everything else, and the use of the fingers, is contralateral, both feeling and moving your fingers. Okay. Everything else, at least cognitively and perceptually, all bets are off. All right, that said, let's look at these different gyri in relation to these three different types of functional subdivisions. We have three. One is modality-specific, one is multi-modal, and one is supra-modal. What do these mean? Well, modality-specific has to do with the senses and movement. So a large portion of the brain is devoted to one or the other sensory modality, or to movement. So primates, what makes primates different from all the other animals is how visual we are. How many of you have dogs or cats? Yeah, I mean, dogs are very sniffy. You know, they're auditory, as are cats, but they're really still, without a little sniff and a lick, they're not really comfortable. And they can do amazing things like sniff out your mood. So look at how much of the cerebral cortex is devoted to vision. So there's input coming from the brainstem, right? Eyes to brainstem to cortex. It first goes to these red areas, and then from the red areas to the blue areas. So that spans occipital, temporal, lobes. These little telephones are the auditory areas. First red, then blue, primary and association. These hands here in the postcentral gyrus and behind, those are somatosensory. Now, there remains some controversy as to whether there's involvement of these with pain. So when I was training, Fred Plum was very old school and really tough and nasty and a really great teacher. I mean, he was great. He was the founding editor of the Annals of Neurology. And if you told him you tested for pinprick and temperature sensation, but not, when you write a number on somebody's hand, it's called graphesthesia, or you put a key in their hand called stereognosis, or two-point discrimination, far versus close, and you were testing for the somatosensory cortex, you got embarrassed. So the problem with functional imaging is, I don't know how many of you are familiar with the philosophical criteria of necessary and sufficient. The functional imaging studies cannot determine whether a particular area is necessary for a particular function. It tells you the area is active, but it doesn't tell you if that particular area is necessary. The lesion effect method tests the necessary criteria. It's not particularly good for knowing all of the areas that are participating. It can't do that. So it has its own problems. But functional imaging, you just don't know which one is necessary. Or even if there's only one, if that's actually necessary. So the functional imaging data are suggesting that these somatosensory areas that they're participating and may be necessary. The lesion effects data indicate that certainly after some period of recovery, they're not necessary for pain sensation, and that it's the brainstem and spinal cord that are necessary. Now, I'm talking about physical aspects of pain sensation, pinprick sensation and temperature sensation. I'm not talking about psychological aspects. Okay. Then in front of the precentral gyrus, there's the motor areas with this pencil in this hand here. Okay. So those are the modality-specific areas. And they present the Humpty Dumpty problem, which is you don't experience the world as a fragmented world. It's some coherent experience, right? It's a holistic experience. So there are two theories about how all of it comes together. One is that the neurons in all these different areas fire in synchrony. So when, these action potentials, which are only 1,000 of a second long, when they occur at the same time, more or less. And so the brain knows, all these different areas know that something's happening at the same time. The more traditional view is that these other areas send those connections. Remember, each of these cells has on average 1,000 connections, that many of those go to these convergence zones called multi-modal areas, these yin-yang sites. So let's take, for example, here in the parietal lobe, axons from the visual cortex will project onto a cell here, the same cell that an auditory neuron will project onto. So unless a visual object is making sound from the same spatial location, that cell won't fire. If it is making sound from the same spatial location, the cell will fire. So there has to be both visual and auditory input from the same spatial location to fire that cell. And that's been clearly demonstrated in monkeys by people like Richard Anderson and dozens of others in the alert monkey. And it's been shown in functional imaging experiments, and most importantly, in lesion effect experiments where patients have hemispatial neglect. If you have a lesion here that neglects half of space for both sound and light. All right, so same thing with touch. There'll be somatosensory input visual input, auditory input. So there's a lot of sensory integration going on there. And that's the idea of multimodal integration. Now, of course, when you see something, you move your eyes to it. That's a form of sensory motor integration. How many of you play a musical instrument? Okay, you know a lot about sensory motor integration. Right, you're doing a lot of kinesthesia, spatial processing, reading a score, listening to what you're playing. So this frontal area here is an area where there's a lot of sensory motor integration. You may have heard the term frontal eye fields would be encompassed here. So this multimodal area does a lot of sensory motor integration. People talk about mirror neurons. They're involved in a fair amount of visual motor integration. Okay. Now the last group, Marcel Messelin, who was someone who influenced me greatly in his book Principles of Behavioral Neurology. He grouped supramodal and multimodal together into multimodal or heteromodal. And I've separated them out for a particular reason, as we'll see in a moment. Let me just stop here for a second and just ask about any questions so far on modality-specific and multimodal. This is a good place to take questions for these two.
You spoke of mirror neurons.
Yes.
Is that distributed, or is it just more in the sensory motor?
So there's sensory and sensory motor in the monkey and in this portion in the temporal lobe. There's actually a lot of auditory visual integration going on in the multimodal. I'm sorry I didn't mention this in the temporal lobe. So there's firing with mirror neurons even if they hear a jar opening and then they're going to open the jar. There's actually some firing that goes on and they get classified as mirror neurons. Again, there's this language game going on with mirror neurons. As you know, it's sexy right now. It's easier to get a grant if you're working on mirror neurons. So it's easier to publish a paper if you call them mirror neurons. So you hear more and more about mirror neurons. So the network that's postulated is, if you want to map it onto my little language game, which is really meant conceptually to limit the vocabulary more, is there's one nidus here, there's one nidus here, and there's one nidus here that maybe bleeds a little bit into supramodal because there's some intentionality. Yes?
Is the level of excitement greater for the neurons that are moving higher visual and sound? Is there a deeper excitement in the system?
That's a great question. No. There's this diffuse projection system that appears to arouse the cortex in general. I can't answer whether it's more one than another, but I know most of my thesis was auditory, well, all of my thesis was auditory cortex, and that became a big issue because I worked with an alert preparation, which no one had done, or very few people had done, and we wanted to know how much arousal was affecting the firing of the cells, and that was actually a big question for a long time, and it was clear that yes, it was going to affect the spike counts that we got, even in auditory cortex. And we thought that wouldn't be true in the sensory cortices, but it'd be more true in multimodal than in sensory. And as it turned out, you had to basically subtract the spontaneous activity of the cells, which was assumed to be the arousal effect, from the activity that was driven by sound, to get what was just sound and not arousal.
And what about cross-modal, as in synesthesia?
You know, synesthesia is such a difficult thing to study at the single cell level, and I don't know the functional imaging literature on that, Dory. I don't know the synesthesia work. I'm sorry. Yeah.
There's been some speculation that people, musicians, because they're working in an affectual, dynamic realm, have hypersensitivity to emotion. How would you explain that in terms of integration?
So let's go to supra-modal and the next slide, because that gets into these top-down levels that we're going to go to after this. That's a great question. Okay, so the supramodal, supra in Greek means above. So a lot of this has to do with things that are going on in the present, right? So I came across these. I was thinking a lot about how the brain was organized, and I came across a couple of quotes. One from a pre-Socratic Greek philosopher, Parmenides, and one from Augustine. Augustine said, rather awkwardly, but kind of nicely, "Neither things to come nor past are. If times past and to come be, they are not as future or past, but present." Yeah. And then the wit, but forgive me, Lord. So the idea that the pre-Socratic Greeks fought over was, and the argument for Parmenides was, nothing exists except the present. Everything else is a figment of your imagination. And if you think about us compared to animals, right, and even monkeys, they really don't have this anterior frontal lobe. That's what apes and monkeys don't have compared to us. And they're very stimulus driven. They're very stimulus bound. Children are very stimulus bound. And this is crazy. Like, when did you start planning this conference?
John, when did you start planning this conference?
Last January it was conceptualized.
Yeah. And everybody, when did they get their airline tickets?
John, when did
I mean, it's like we're crazy, it's like this planning in advance, So there's a simple way to dichotomize it with it, dichotomies have their problems, but to simplify it, there's a large part of the human brain that brings the future into the present, and a large part that brings the past into the present. And they're supramodal because they're not dealing with the present. Right? And you can throw a lot of, we reflect way too much. I mean, talk about psychopathology. We're always, worried about this, or worried about that. And it's very human to kind of be living inside yourself instead of, there's the famous John Lennon quote, right, from, what's the song?
Watching the wheels.
Watching the wheels,
Life is what happens when you're busy.
Making other plans. So, and the anterior frontal lobe is involved with bringing the future into the present. And the medial temporal lobe, medial temporal lobe, is involved with bringing the past into the present. And the terms that you hear, so the limbic system, what does limbic in Greek mean? It means the lip. So doesn't that look like a lip? Sort of. So whenever you hear limbic system, somebody is saying to you in some coded way that's been elaborated on from the original use of it, the structures around this lip. Okay? So you've heard this is the parahippocampal gyrus, and in there is the hippocampus, parahippocampal. This is the amygdala. This is the cingulate gyrus. Okay. So these are the supramodal areas that are involved with these things that are not immediately, in front of your eyes, ears, and so forth. All right. So let's think about how these are organized in the brain and how they might relate to music. I like to think of nervous systems as things that have evolved at the interface between the inner self and the external world. It's hard to get philosophers to agree with each other, too. I think we probably can get almost all of them to agree with two distinct realms of everyday experience, the inner self and the external world. So we have stimuli impinging upon us all the time from the external world, and we've developed these peripheral organs that deal with handling the information that's impinging upon us from the external world, and that is the peripheral nervous system and the spinal cord. And of course, the peripheral nervous system and spinal cord are connected with muscles and bones, etc., that exert the force of our actions back out into the external world, right? So there's this interface that we have with the external world. Now, on the sensory side, or called the afferent side, the peripheral nervous system projects up into the central nervous system, where I'm going to lump the brainstem and cerebellum into the subcortex. At the expense of my colleagues, a number of my colleagues would kill me for this step and lumping them because they've spent their lives working on the brainstem and peripheral nervous system. But I'm a cortex kind of a guy, so my apologies to my many great colleagues working in the subcortex.
I think you're okay here.
Yeah, I'm okay here. Now, the subcortex, which includes the thalamus, which many people, especially clinical neurologists, would attribute the conscious perception of pain to, projects, all projections are reciprocal, also projects down into the peripheral nervous system, to the spinal cord and onto the peripheral nervous system. It also projects up into the modality-specific cortex, which we've already covered, right? The auditory, visual, somatosensory areas. I didn't cover olfaction and so forth. Those areas are smaller. They're there. All the senses are there. It's just harder for me to draw them, and they're smaller, so I left them out. The modality-specific cortical areas project up to the multi-modal areas, which we covered. And then the multi-modal areas project to the supra-modal areas. Right. Now, I said that the supra-modal areas transcend the interface between the self and the external world. The correct way to say it is that they can transcend the interface. However, they do interact with the external world. And that's very much captured by the notion what you know about the world influences how you perceive it. Now, in the parlance of cognitive psychology or psychology in general, this left-hand side of the arrows here is called bottom-up processing. That's sort of the buzz term in current psychology. It's called bottom-up. And a lot of the notions of bottom-up processing are attributed to John Locke in his 17th century essay into human understanding, where he said at birth, the human mind is just a blank slate and can acquire only basic knowledge of the world through the senses. After the initial process, experiences can then be categorized and stored in memory. So that's what's known as bottom-up. And he's caricaturized in this because eventually memories are formed according to this and influence things top-down. But his idea has to do with the innateness of the ability to categorize. He thought you had to have experience first, and then you would categorize the information after you had experience. Now, this bottom-up processing, because it goes station to station like the 6 train, is also known as serial processing. And because one is drawn higher than another, it's also called hierarchical processing. So all those terms are synonymous, more or less synonymous. However, there's also parallel processing. So actually, these supramodal areas do get input from the modality-specific areas, as well as from the multimodal areas. And although I haven't really drawn them in, there's some subcortical projections that are described, although they're so small, people really don't think they're worth an arrow, oftentimes, and that they might be too confusing to put in a talk like this. Right. It's that they're not worth the simplicity and comprehensibility of a model. But what is worth it is understanding that there's parallel as well as serial processing. And it's not as simple as we thought it was a few decades ago. Oh, I actually did put it in. All right, now Immanuel Kant, who many consider the pioneer of cognitive psychology, took issue with this notion and said, look, from the get-go, from the time you're born, you can't be just like a sponge. That's not how it works. And I think a lot of you who work with infants know the infant literature has pretty much borne this out. The mind organizes and systematizes what we experience with its own programmed intuitions and categories, which makes sense of all the data that constantly floods through our senses. And this is when psychologists talk about top-down processing. They're saying that the cortex plays a role in this bottom-up processing. It's actually playing a role in selection and organization and filtering and cognitive processing, and that at every stage that you have this bottom-up, there's reciprocal connections. And we used to not really, and we still don't really understand, especially at the single neuron level, a lot about these reciprocal connections, but they're there because they're playing a very active role in this processing of bottom-up information. And this is where the notion of all our inherent biases about the world, where we grew up, what we learned from our parents, what we learned by culture. I'm in the midst of reading a little introduction into existentialism, where one of the problems is supposed to be that we actually never think for ourselves. So we're so inculcated by culture and reading and books that we don't even have a mind of our own anymore. You know, and then the question is, well, what are we supposed to do? Burn all the books? You know, in the days before the 1800s, when people tilled the land and so forth, they were much more in commerce with themselves and the earth. Now you never are yourself. You're just a product of mass society. All right, so that's a big picture view of how the brain works with lots of criticisms that I and my colleagues could levy at it, but at least a working knowledge. How am I doing on time, Joanne? Okay. So let's think about how that might apply to music. Well, it should be clear that the whole concept of auditory analysis and representation is going to be in the modality-specific part of the cortex that is involved with auditory processing, auditory analysis and representation. So a lot of my own work over the years that Joanne alluded to has been looking at lesion effects and how they affect pitch and harmony perception, loudness perception, timbre perception, and so forth. There hasn't been as much work on other topics like equivalence and transposition, which, by the way, we can do, but old world monkeys really can't do except for octave equivalence. And that's a much more cognitive aspect. Of course, auditory spatial cognition, having to do with arrangements and mix and panning in the studio. There is some work on auditory spatial cognition and auditory virtual reality. But any of us really, whether it's therapy, whether it's writing songs, the holy grail is evoking emotion in the listener, right? And this is really what we are talking about in this conference about pain, is getting into affecting excitement, heart rate, maybe releasing endorphins. I'll defer to Dr. Carr about how hard it might be to measure those sorts of things. But what I would emphasize for the therapist, since I'm running out of time, in the little work that I've done with the therapy, heart rate is actually something that you can measure fairly easily and provides a window into the clinical effects that connects with what we're talking about with the brain. Referential route. The absolutist route is music-specific, having to do with music-specific rules. And the classicists typically, but even in pop music, we make use of these rules all the time. And they have to do with expectancy, generation, violation, and satisfaction. One of the universals in music, according to some ethnomusicologists, has a lot to do with repetition and return that's already built in. For those of you who know the lingo, appoggiatura, certainly cadences generate very strong expectancies, changes in tempo, changes in key. All of those are basically playing with expectancy, generation, violation, and satisfaction. And since in music, much of what we do is to generate, you're looking ahead, right? You're looking at what's about to happen in the future and then influencing that. There's been work with event-related potentials, much of it done by Stefan Kulch. I've collaborated with Stefan. There's a lot of psychological data on this. There's evidence that these supramodal areas contribute to this, and that by violating expectancies, you can generate changes in heart rate and skin conductance and so forth. So one route to go by that, and you know, obviously a trivial example, if you do something, right, that's a music-specific type of violation. There's no referentialism to that other than what you know about music. The referential route, which is what Meyer emphasized more heavily, which I tend to actually disagree with a bit, has to do with associations with people and past events. However, in the music therapy context, we saw yesterday how powerful that could be. I think you talked about kinship relationships and how, you know, bringing in things that are specific to a particular family and familiarity, how much of a role that could play. And how cultural context plays an important role. Outside the music therapy context, the association with particular cultural events, funerals, weddings, and so forth. All of that is very important in generating the emotion associated with that particular music. So the context and the association with something that happened in your life, your first dance, your first kiss, your wedding song, and so forth, those kinds of things play a very important part in evoking emotion and meaning in music, and those are more likely to be associated with these medial temporal lobe structures. And Isabel Peretz and her colleagues have looked at some temporal lobectomy patients where the amygdala was removed and have demonstrated that they have some decreased autonomic responses in relation to music if they've had these medial temporal lobe structures removed. So the supramodal past regions are related to those. Now, what hasn't been emphasized, I think, enough in the literature, and maybe because so many of my colleagues are more classicists than rockers, is the idea that all of the different modalities are involved in music, really. It's not just about sitting there in a chair and listening. You know, if you're from the MTV generation, you know it's not just about the song, it's about the video. And when you go to a club or you go to a concert, you move and you dance, and there are languages that don't have separate words for music and dance. It's an odd European tradition in a sense compared to some other cultures. So kinetics and kinesthetics, which are related more to these multimodal areas and to the sensory motor areas, play a very important role in getting your heart rate up and getting excited about music. So I don't know how many of you are involved with drum therapy or in having people sing along with the therapy with you, but actually feeling yourself moving and actually participating in it has, I think, a very powerful role in generating emotions in the context of music. And of course, visual perception, actually seeing someone else participate with you and seeing a person there, that addresses the questions that I've had, and I think all of us have, about, is recorded music enough? Do you need to actually have another human being there who you can relate to? In music and pop, it's obvious you want to have someone who looks good or looks funky, or the stage design, the scene lighting, the motion, how you cut the video, all of that's really important. In music therapy, how much does the setting and how you set up the setting, the lighting, all of that, how much does that play in, and how you're going to set up your clinics, your offices, and so forth to induce mood in relation to the effectiveness of the therapy. I would just encourage everyone in their outcome measures to try to be a little bit more quantitative. I have my own sets of problems with these questionnaires, but I think we have to use them if we want to be quantitative. I don't think there's any way around it. And I think that the cost of things like heart rate monitors or galvanic skin response, they're not that high. I think it's the programming costs maybe on the other side, the software cost to actually get a measure out of it, but even those are going down now with laptops. So if you could combine a psychological measure or two or three with an off the, kind of a package that comes down that allows you to measure mean and heart rate and standard deviations and maybe an RR prime interval, those are the kind of quantitative measures that can maybe take studies of pain to the next level and not really think about that you have to do fMRI or anything like that, but that you can get at emotion and its visceral concomitants and connect it to the brain in a fairly straightforward manner through other people's research that they've done in the field. Now I have a whole nother bunch of slides, but as I told everyone yesterday, I always prepare 18 more slides than I give, and it's
two more in conclusion.
Oh, okay. Well, personality and preference, I'm going to leave that one out. I'm just going to go to my. Oh, I just have to tell this joke slide. You know, Aristotle said, since I'm pushing for measuring heart rates and things like that, that the heart is the organ of intellect, right? He was 330 BC. You know, Hippocrates did a lot of lesion effects work. So I have here for him, what do you do about the youth of today? Haven't you read my work? It was 200 years before Aristotle. It's hard to believe that Aristotle did not do that. Joanne, I'm sorry, I'm going to have to skip all the stuff that you published in your journal. You want? That's okay? All right. You want to see one slide of that, or?
No.
Okay. All right.
I don't.
You don't care?
I don't care about
All right. All right. So over the past 2 decades, there's been a lot of research in humans and animals that's advanced brain knowledge about brain mechanisms mediating music, cognition, and emotion. And I think there's a lot of that for you to draw on in the work that you're doing. And your experience with music therapy has a very long and rich history. And whether it's anecdotal or not, that provides a rich source for generating testable hypotheses about how to use that scientific knowledge that's been accumulated to treat pain in children and adults. So the confluence of the scientific advantages and the clinical experience and insight hold great promise for a new era in music therapy research that can incorporate rigorous data collection and analysis methods with the randomized controlled clinical trial designs that are being brought out. But I don't think to the exclusion of the one-on-one psychotherapy models. And I think this is a point of discussion that I tried to bring up yesterday is what are the clinical contexts that are appropriate for randomized clinical trials versus the more psychotherapy-oriented one-on-one models? What are the disease states? What are the patient populations? How can we start or continue, I think already, the dialogue about stratifying the different types of patients and disease states so that we don't get negative data because we've chosen the wrong population and the wrong method, and at the same time get a more likely positive results because we have chosen the right patient population and the right method, so we can move the field forward and get more funding and do more studies. Okay, thank you very much.